Hey guys, and welcome back to another video by Big Derm Energy. Today, Big Derm Energy does Acne Vulgaris. And what is Acne Vulgaris? Well, Acne Vulgaris is a multifactorial disorder of the pilosebaceous unit that results in the characteristic lesions including comedones, papules, pustules, and nodules. And as I always try and do with each lesson, here is a little bit about the derivation of the word. The term acne may have been a bastardization of the word acme, meaning peak, or it may have been an original word. Truth be told, no one actually knows. And vulgaris is simply the Latin word for common. What causes acne vulgaris? And this you will need to know. There are four basic pathophysiologic factors that cause acne vulgaris. Number one being follicular dyskeratinization and hyperkeratinization. Two, increased sebum production. Three, bacterial influences by Propionibacterium, or as it's now known, Cutibacterium acne. And inflammation. And in short, the story goes like this. Follicular dyskeratinization and sticky sebum under the influences of the androgens like testosterone and 5-DHD cause follicular plugging and the formation of a microcomedone. This microcomedone is the most basic acne lesion, and all other lesions, be they tiny papules or massive nodules, start as microcomedone. This sebum-rich environment inside the microcomedone serves as a nice place for P or C acnes to grow. I'm just going to call it P acnes from this point on, but P acnes results in the release of cytokines and other inflammatory mediators, which leads to a localized inflammation. The P acnes also releases an enzyme that helps weaken the lesion wall and can cause it to rupture. Once it ruptures, this lesion releases all of the P acnes and sebum and inflammatory mediators into the surrounding dermis, leading to an even further inflammatory event. And here's a nice graphic just showing you what a healthy pilosebaceous unit looks like. This one has been infected by a little bacteria, a little P acnes, and it's sealed so the contents are white. This one is open and the contents are black, and the reason being is that in this area the sebum has been affected by oxygen. It's been oxidized and turns black. In this area it is white. Moving past the blackhead though, we have the papule, where we have not only the bacteria, but we have the white blood cells attacking the bacteria, creating some inflammation. And finally, in a pustule, we have the inflammation, we have the bacteria, but we also have white blood cells and waste products from the bacterial reproduction that result in this larger pustule. And here is a nice graphic taken from Bologna's textbook, which shows not the normal pilosebaceous unit, but does show the early comedone caused by hyperkeratosis and increased corneocyte cohesiveness in the upper sebaceous follicle. Later you have the later comedone, and then you have the inflammatory papule or pustule, and then you have the nodule or cyst, which is marked by marked inflammation, and these lesions may lead to scarring. Acne in and of itself, especially in a teenager or adolescent, is something that we're going to see every day. And it's pretty easy to recognize the patient that comes in. However, there are a couple of clinical variants that I do think are probably worth knowing. The most important one is acne fulminans, emphasis on full, F-U-L. And this is the most severe form of acne. It's seen usually in young teenage boys, and you have this abrupt onset of the suppurative nodular lesions in conjunction with systemic manifestations such as fever, muscle aches, malaise, and hepatosplenomegaly. Blood work is going to show an elevated ESR, leukocytosis, and an anemia, and there may be proteinuria on UA. In addition, erythema nodosum and osteolytic bone lesions may be seen with acne fulminans as well. And this was actually a case in one of the journals not too long ago where they talked about this. To treat acne fulminans, you're going to have to pull out the big guns. You're going to start with prednisone for 2 to 4 weeks, the standard, half milligram to 1 milligram per kilogram per day dosing. And then after 2 to 4 weeks, then you're going to start on low dose isotretinoin therapy, and low dose as in 0.1 milligrams per kilogram per day. And you're going to stay there for at least a month. Eventually, you'll increase the tretinoin and taper off the prednisone over the course of 1 to 2 months. The alternative, or the one that's often compared and contrasted with acne fulminans, is acne conglobulata. And the way that I like to remember that is acne fulminans. You are full of acne. You have these full systemic systems, and it's a serious condition. Acne conglobata is kind of a con, if you will. You still have the severe acne like you do in acne fulminans, but you don't have those systemic symptoms. It is also part of the follicular occlusion tetrad, and this includes acne conglobata, hidradenitis suppurativa, pilonidal sinuses, and a dissecting cellulitis of the scalp. Next, we have drug-induced acne, and drug-induced acne, at least in our area, you're going to see it with steroids, either topical, oral, or testosterone replacement therapy. You can also be caused by lithium and isoniazid. One of the important things about drug-induced acne is it tends to be monomorphic. In other words, instead of seeing papules and pustules and blackheads and cysts, you're going to see a bunch of lesions all in the same level of development, all papules or pustules, and they're all going to look very monomorphic. After that, we have occupational acne, and this is due to oils or petroleum-based products, coal tar derivatives, that sort of thing. Chloracne is an important one, and this is an occupational acne specifically due to halogenated aromatic hydrocarbons that you can find in electrical insulation and in agricultural pesticides. And on clinical exam, you're going to see comedones and yellowish cysts without inflammation on the cheeks and behind the ears, under the arms, and in the scrotum. And finally, we have acne mechanica, acne cosmetica, pomade acne, tropical acne, and radiation acne. And the name says it all for those. Cosmetica is due to cosmetics, pomade is usually due to a hair care product, tropical is just a tropical environment, and radiation is obviously due to radiation for treatment of a cancer elsewhere in the body. Now, once you have identified you're treating acne, which once again we're going to have to do probably several times a day, you have to know how to treat it. And in my opinion, the mainstays are still retinoids, or what used to be called retinoid-like medicines like Differin or Adapalene. Topical antibiotics, although there's some question as to whether they may still be effective at this point. Oral antibiotics, spironolactone for women, and oral isotretinoin for severe acne that is recalcitrant to other forms of treatment, or that acne that has significant scarring. Starting with the retinoids, here we're talking about the topical retinoids. The topical retinoids are all derivatives of vitamin A, and they're effective in the treatment of acne due to their ability to normalize the life cycle of the follicle cell. And they prevent the formation of the microcomedones, which is the precursor to all of the acne lesions. And they do this by reducing keratinocyte proliferation and promoting the cell turnover. This helps to unclog pores. And they may have some anti-inflammatory effects as well. But one of the things that I like to tell my patients is the retinoid, whether it be tretinoin or tazarotene or Retin-A or Adapalene or Differin, it's the only class of medicine that I can give them that's really going to stop the acne before it starts. Everything else is just going to take a lesion that's already formed and maybe help it go away quicker or help it not get as large or inflamed, but it's not going to stop it before it starts. And taking a little bit deeper dive into the retinoids, the topical retinoids in this case, they work by binding to specific receptors in the nucleus of skin cells, known as retinoic acid receptors and retinoid X receptors. And these receptors, as all receptors, they're types of proteins. And when a retinoid binds to it, it changes the shape of the protein and changes the way that that protein interacts with DNA. This can lead to altered transcription of specific genes, changing the way the cell behaves. In the case of acne, this altered transcription can lead to decreased proliferation of skin cells and an increase in cell turnover, which effectively prevents the blockage of hair follicles that can lead to the formation of acne, specifically the microcomedone. Once we've started on the topical retinoid, the next step is usually going to be, and I do this in conjunction, by the way. I don't do these stepwise. I'm not a big fan of stepwise therapy, but I will also usually start them on a topical antibiotic. The primary mechanism of the topical antibiotic, in this case, clindamycin or benzoyl peroxide or erythromycin, is through a reduction in the P. acnes bacteria. And this P. acnes bacteria causes inflammation by producing certain substances that lead to sebum breakdown, and it creates a pro-inflammatory environment. By suppressing or decreasing the number of P. acnes, the topical antibiotics reduce this inflammatory response. And as I mentioned, clindamycin and benzoyl peroxide are the most commonly used. Clindamycin may or may not still be effective at this point. I do still use it, though, in combination with benzoyl peroxide. in a product which used to be called Benzaclin or Duac. Now I'm not sure either one of those are still available. I think it's just generic clindamycin and benzoyl peroxide in combination. Taking a deeper dive into the oral antibiotics, the topical antibiotics. The topical antibiotics such as clindamycin or erythromycin inhibit bacterial protein synthesis by binding to the bacterial ribosome. When they bind to the bacterial ribosome, this prevents the bacteria from carrying out vital processes and ultimately leads to the death of the inhibition of the growth of the bacteria. By reducing the amount of P. acnes on the skin, these antibiotics help to reduce the inflammation and lesions caused by acne on the skin. Unlike topical antibiotics, which may or may not still be useful, oral antibiotics, I think, are unquestionably still useful in the treatment of acne vulgaris. There's some controversy as to the length of time that the patient should be on them, and we certainly try to get the patients off of them as quickly as we can. However, if you've been doing this long enough, you do know that you're going to run into people who do great when they're on doxycycline or they do great when they're on Bactrim. But unfortunately, as soon as you try and stop them, the acne comes back. And for whatever reason, they're not interested in, they're not candidates for isotretinoin. So although we try and get them off them as quick as we can, we do still have to use oral antibiotics in the treatment of acne. And they work in a very similar fashion to the topical antibiotics in that they reduce the number of P. acnes on the skin. And antibiotics, specifically doxycycline, have both antimicrobial and anti-inflammatory effects. And because they're systemic, they can reach the sebaceous follicles that topical treatments may not. And this tends to make them more effective for moderate to severe or widespread acne. And as I mentioned above, tetracyclines like doxycycline and minocycline are commonly used due to their effectiveness and their anti-inflammatory properties as well. And keeping with what we discussed earlier, we're going to take a little bit of a deeper dive into the oral antibiotics and how they work. And as oral antibiotics for acne, such as the tetracyclines, mainly doxycycline, they work by inhibiting bacterial protein synthesis. The tetracyclines bind to the 30S subunit of the bacterial ribosome, and this prevents the attachment of amino acid tRNA to the mRNA ribosome complex. I don't know what that means, but it says it here, so I guess I better read it. Actually, I do know what it means, but it's probably not worth getting into. This blocks the addition of new amino acids to the growing peptide chain, thus inhibiting the protein synthesis. By inhibiting protein synthesis, these antibiotics work to limit the growth and the proliferation of Propionibacterium acnes, and this, of course, reduces the associated inflammation of the acne lesion. And I didn't cover any of the side effects for the tretinoin and the topical antibiotics because they're all fairly well known. With the retinoids, you're going to have some dryness and some irritation, and with the topical antibiotics, same thing, a little dryness, a little irritation, but minimal, really nothing to kind of write home about. But for the oral antibiotics, there's a little bit more going on. You can have gastrointestinal disturbances, and we see this with doxycycline. These include nausea, vomiting, diarrhea, or loss of appetite. And one of the things we do recommend is that the patients take the medicines with food, as this can certainly reduce those potential side effects. Photosensitivity, we're going to see with the tetracyclines as well, and this is fairly common. We just recommend sunscreen when they're going to be outside for any amount of time. Dizziness or lightheadedness, we see this more with minocycline than anything. And it's advisable not to drive or operate machinery if you experience this side effect. I think we all know that. Discoloration, skin, scars, teeth, or gums. The tetracyclines can do this, and this is why we don't give them to younger children. Depending on the source you read, either 8 years or younger or 12 years or younger. For me, I like to make sure that they have lost all of their baby teeth and their adult teeth have grown in before we give any doxycyclines. Yeast infections, as with any antibiotics, this can be an issue, more commonly to be an issue in women than in men though. Esophagitis and esophageal ulcers. We see the esophagitis with the doxycycline, and the instructions that I always like to give are to take the medicine with a full glass of water, not just the sip of water that most of us do, and to not lay down within about a half hour to an hour after taking the medicine, just to give it the opportunity to make it all the way to the stomach. And less common but more serious side effects can be severe headache, vision changes, or a hypersensitivity reaction known as DRESS, which is drug rash with eosinophilia and systemic symptoms. Next, as far as terms of treatment of acne, we're going to go to the big gun, which is isotretinoin, formerly known as Accutane, and apparently also now again known as Accutane because I think somebody bought the rights to the name and they're re-releasing it. I'm curious as to whether it is the true formulation of original Accutane that was put out by Roche, or if it's just another formulation and they're just using the name. And the reason I say that is because having used brand name Accutane for many years in the beginning of my career, it worked, and it worked very, very well. When the generics came out, all of which ended up being branded generics, there were some, and I won't mention any names, but there were some that I found to be not nearly as effective as the brand name. And there was one specifically that, and I don't think it's still around, but that whenever I had a patient who was not improving the way that I thought that they should, or who was having a side effect profile that was more exacerbated than I thought it should be, almost invariably they were on this one branded generic. But isotretinoin, as it's available now, is still the biggest gun we have, and it's still the closest thing that we have to a cure for acne. It's a systemic retinoid that's typically used in the treatment of severe or resistant forms of acne that haven't responded to previous treatment regimens. And this works by dramatically reducing sebum production and normalizes the way skin cells are shed. This prevents the formation of the microcomedones, which is, of course, is the primary lesion of acne. It also reduces the population of P. acnes on the skin and has a powerful anti-inflammatory effect. So you can see that of all the medicines we've talked about, isotretinoin is the one that works on all four pathophysiologic factors of acne. It has side effects, so it's not something we hand out like Tic Tacs, but what I always say is if you give isotretinoin or Accutane to the right patient at the right dose for the right amount of time, they're going to tolerate it really, really well, and they're going to get great results from it. And the dose that we use for that is usually about 1 milligram per kilogram per day. It used to be we did it for 6 months, and then it went down to 4 months, and now it's 4 to 6 months. But really, I like to do it until I get at least 2 months with no significant acne. If we've dosed them correctly, and the last 2 months they haven't had any significant acne, I think they're going to have a very good result. And I always like to tell patients that because of the way Accutane works, you're going to continue to see improvements for up to 3 months afterwards. So just because we stop at 6 months doesn't mean that's where we end up. We're still going to get better after that. As far as the mechanism of action of isotretinoin in acne, similar to the other retinoids, it exerts effects by binding to the nuclear receptors, the RARs and the RXRs, and this affects gene expression. One of the most significant outcomes is the reduction of the size and the secretion of the sebaceous glands. And as I said before, it's the only medication that has effects on all four implicated pathogenic factors. It normalizes desquamation, which is your dyskeratinization and hyperkeratinization. It decreases sebum production. It reduces P. acnes proliferation, and it has anti-inflammatory properties. And by acting on all of these different factors, this is really the only comprehensive treatment that we currently have to treat the most severe forms of acne. As far as the side effects of isotretinoin, and this is where it kind of becomes, I won't say controversial, but this is why we have the whole iPledge system, and specifically about the last side effect that we're going to talk about here. But dryness. Isotretinoin works in part by reducing the amount of oil produced by your sebaceous glands, and this often leads to dryness of the skin, lips, and eyes, and nasal passages. So all of our patients are going to be on lip balms. I happen to like Dr. Dan's Cortibalm, but Aquaphor, although not as cosmetically elegant, also works. Saline eye drops, saline nose sprays, moisturizers, all of those things. As a matter of fact, the dry lips is such a common side effect of Accutane or isotretinoin that if you have a patient that is coming in and is taking the medicine as directed and they don't have dry lips, that's considered a treatment failure at that point. That means the medicine really isn't doing anything for them. After dryness, you may have some muscle and joint aches, especially of the muscles of the back. I see this more in my particularly active patients, the ones who are playing competitive high school or junior high or sports. Those are the ones who tend to get the back pain. It doesn't usually limit them. It's something worth asking about, but I'm not particularly concerned about it in my athletes. Isotretinoin can certainly make you more sensitive to the sunlight, leading to a higher risk of sunburn. And I always tell my patients to always wear sunscreen when you're taking the isotretinoin, because I promise you, if you get a sunburn, you will only do it once. You will never want to go through that again. I have seen some really bad sunburns in some of these kids on isotretinoin that didn't follow the sunscreen advice for one reason or another. Mood changes. Some patients do report changes in mood, including symptoms of depression or anxiety. This is kind of a controversial one, at least in my opinion, and I think in the opinion of many others. We screen for it and we ask about it, and I particularly am worrisome. It's particularly worrisome in patients who have a strong history of depression or anxiety. But in all honesty, so much of being an adolescent, so much of being a teenager, as far as the way you feel and the way you act, is based on the way you looked and the way you're perceived by others. Right or wrong as that may be, it's the God's honest truth. And when we have kids that come in that we've put on Accutane, after a couple of months, for the first time in likely years, they're going to have clear skin. They're not going to have this severe nodulocystic scarring acne. And they're going to be more confident. They're going to be more outgoing. And that's what we see. We see more confident, more outgoing, more happy, more social teenagers because their appearance isn't holding them back for the first time in many years. So yes, we do screen for it, but clinically, we tend to see the opposite. We tend to see happier, more outgoing, more positive teenagers. Elevated blood lipids and liver enzymes, we do test for that. We do blood work monthly, which is a CBC, a CMP, and for women, a lipid panel. And for women, we will do a pregnancy test as well. Again, kind of controversial. I think a lot of providers would like to see that monthly requirement go away. And in some places it's not a requirement, but where I am, it's still standard of care to check the blood monthly. So that's what we do. One of the most serious considerations with isotretinoin, though, is that it is pregnancy category X. It's teratogenic, meaning it can cause serious birth defects if taken during pregnancy. And this is where the issue with iPledge comes in. And iPledge is a whole nother topic all in of itself. But it's a system that is government mandated that puts into place certain requirements that must be done by the patient and by the provider before the prescription can be filled. And once again, the reason why that is not because of the first 5. It's because as many as 9 out of 10 babies that are conceived on Accutane will have serious, if not fatal, birth defects. All right, so we've done a nice sort of what I think is a comprehensive coverage of acne, including the basic pathophysiology and the 4 pathogenic factors, the treatments, some of the more common side effects of the treatments, and some of the more esoteric and a little rarer acne-like conditions. But here is our Acne Vulgaris elevator pitch, the Big Derm Energy Acne Vulgaris elevator pitch. And that is, acne vulgaris, or common acne, is fundamentally a disorder of the pilosebaceous unit that results in any one of the typical acneiform lesions, including comedo, papules, pustules, cysts, and or nodules. The pathogenesis is multifactorial and includes at least the following 4 components: follicular hyperkeratinization and dyskeratinization, increased sebum production, bacterial influences by P or C acnes, and inflammation. The treatment of acne vulgaris is often multimodal with the goal to target each of the factors above. The only medicine we currently have that targets all of the factors above is isotretinoin. And there we have it. That is all of the shit that I think you should know about acne vulgaris. I probably missed some things and I probably left some things out, but overall I think that's a pretty good comprehensive covering of the topic. And that is all I got. I hope you guys enjoyed the presentation. The end.